Good evening, everyone. It's nice to see so many people have joined the webinar tonight. I would love for you to ask as many questions as you like in the chat box, and I'll be monitoring the chat box throughout the course of the webinar. So if you've got questions, please feel free to type away. We've got Bianca on standby if there's any technical issues, so please let us know and she'll deal with those. Just first things first, I'd just like to acknowledge the traditional owners of the lands on which we meet today and pay my respects to their elders past and present, and extend that respect to other Aboriginal and Torres Strait Islander people who are present on this webinar this evening. For those of you who don't know me, my name's Angela Newbound. I have been providing immunisation program support to providers and program information and education around the immunisation program for about the last 18 years. I'm based in Adelaide. I'm an immunisation education consultant, but I am also the Immunisation Hub Coordinator at the Adelaide Primary Health Network. So I'd like to thank the Immunisation Coalition for inviting me to deliver this webinar for you all tonight, and our topic is pertussis. So I think those of us that are, all online here, we're probably health professionals of some description, I would imagine, nurses, doctors, pharmacists maybe. We're all aware of pertussis. We know that it's a terrible disease. We know it's been around for a very, very long time. First described actually in the 16th century, but really was only first isolated in 1906. But during the 20th century, pertussis was one of the most common childhood diseases and was certainly a major cause of childhood mortality. And that's really quite evident when you start walking around old cemeteries where things like diphtheria and whooping cough were major causes of childhood mortality. Caused by the bacterium Bordetella pertussis, these particular pertussis antigens really appear to allow the organism to evade our host defences. So normally, respiratory tract, it's got sticky mucous membranes, we've got, hairs in our nose and all of those sorts of things that are there to keep out these sorts of organisms. But this one does tend to evade those defence systems. The bacteria itself attach to the cilia of the respiratory cells, and then they produce toxins. So it's not so much the bacteria that causes the infection in one sense, it's the toxins that they release that causes the damage. And these toxins then paralyse the cilia, they cause inflammation of the respiratory tract, and that inflammation interferes with people's ability to be able to clear mucus from the respiratory tract or any secretions from the respiratory tract. So one of the key features of pertussis infection is this horrible mucus that people are trying to cough up. It's very, very thick. It contains pus. It contains blood. And the problem with that particular exudate is that it's so thick it blocks the airway very, very easily. And of course, that's, especially in young infants, exceptionally dangerous. So because they try so hard to cough it out, they have this terrible cough, they can turn blue, they can develop pneumonia from this particular bacteria, and they can also have lung collapse as well due to those airway blockages. So really, really serious disease, and particularly for little babies, you can fully understand. very highly contagious, and that causes a great big problem when we have populations of highly susceptible individuals. So we've got populations of unvaccinated individuals, unvaccinated either because they're too young, unvaccinated because they've chosen not to vaccinate, etc. So it is highly infectious, spreads to about 70 up to 100% of susceptible contacts within the household. So if you're living with somebody, you're going to increase that likelihood of spread. But even with kids going to school with this particular disease, if you've got susceptible individuals also at school, up to about 50 to 80% of those susceptible contacts will actually become infected. There are some guidelines from the CDNA that will assist with diagnosis and management of pertussis cases, particularly if there's going to be a public health response. So in regards to public health responses for this disease, a case is considered to be non-infectious at whichever time is the earlier, either 21 days after the onset of cough or 14 days after the onset of a paroxysmal cough, or when the individual has completed 5-day course of an appropriate antibiotic. So that infectious period for being up to 3 weeks is really important for us to understand, and as health professionals to be aware of if somebody is presenting to you or your practice with a persistent cough. Whooping cough is really difficult to diagnose because it often doesn't appear to be a typical whooping cough in the fact that the person can still complete a full sentence maybe. They're not having paroxysmal coughs. They may not have post-tussive vomiting, so that vomiting post-coughing episode, and they certainly may not have the whoop. But during that 3 weeks where you're trying to perhaps diagnose why this person has a very irritating cough, if they are infectious with pertussis, they're spreading it around. So it's a really tricky disease. So if you look at the symptoms of pertussis, obviously that runny nose is one of them. That cough, it's just a really annoying cough, particularly for adults, where it's just a cough that won't go away, and that can last for a considerable amount of time. It's often referred to as the 90-day or the 100-day cough, very much so with, the fact that adults won't hoop. It's generally, the hooping is generally seen in young children, but is usually absent in the very young infants. Very young infants tend to just stop breathing. People can have really severe vomiting and to the point that they will, severe coughing that they will vomit afterwards, and it will make them feel just generally really quite awful. You can see the possible progression of this disease. This doesn't mean that everybody will get these particular symptoms. Everyone's going to be a little bit different. No one's a textbook. But you can look at that stage one where realistically, how as a medical professional would you be diagnosing or thinking that this is whooping cough? This could be just a regular seasonal cough. It might be the start of a flu. It's just so typical of so many disease onsets. Once people get into that stage two, they may well have this paroxysmal coughing. Now, people that have got whooping cough quite often cannot string a full sentence together without having a coughing episode. So that's absolutely characteristic of whooping cough. Like I said, the hoot may or may not be there, depending on the age of the individual. Vomiting may or may not be there. But then that convalescent stage can actually take a very, very long time. Complications of pertussis, we certainly don't want people getting to this particular stage. So early diagnosis, if at all possible, is paramount. As we said before, this horrible, thick, pus-filled secretion that people cannot clear from their lungs definitely can cause a pneumonia. Obviously, difficulty breathing. When somebody can't breathe well, then they're starving themselves of oxygen, so that obviously can lead to seizures and brain damage. Kidney failure is one of the other things, which is really quite surprising. But why would you think, why are kidneys involved if this is an infection of the respiratory tract? But the kidney failure would usually occur because of the really strong response to the inflammatory process caused by those pertussis toxins. Clearly, people can just be vomiting that much that they're not eating and will lead to weight loss. And of course, as we well know, death is just a horrible complication of this particular disease, particularly in those very, very young infants. Infants are most vulnerable up until the time that they have their first vaccine. Thankfully now, and we'll talk about the maternal pertussis program a little bit later on in the slide deck, but prior to us vaccinating pregnant women to get those antibodies through the placenta and into those little young babies, so babies are now being born with a degree of protection from those maternal antibodies. But prior to us vaccinating pregnant women, these little babies were really at very, very high risk of dying from a pertussis infection if they were going to become infected before they had their first dose of vaccine. And it was always viewed that the first dose of pertussis-containing vaccine was going to save a baby's life. The second dose would reduce the likelihood that that baby will contract pertussis but be hospitalised because of it. And the third dose of pertussis-containing vaccine is going to reduce the likelihood that this child will get pertussis. So it was really important that little babies did present early for their immunisation program to commence. For as long as parents delayed their immunisation program commencing, the wider the window of opportunity was open for these babies to contract this horrible disease. So thankfully we've got a maternal pertussis program that's really affording some protection to those little tiny babies. So just before we do the poll, there's just a question in the box. If a patient who has had pertussis illness, how long do we need to wait, if at all, before giving pertussis vaccine? Look, the jury is out, is the bottom line with that. We've been asked this question a number of times and there's several different responses, but there's really not a great deal in writing. Some providers will suggest that we wait 12 months after a dose if somebody has had pertussis disease that has been medically diagnosed and confirmed. Other experts will say this will naturally boost our immune system for perhaps 2 to 3 years, so there is no point in giving a pertussis vaccine inside of that. But we would just be really advocating that anybody that hasn't had a pertussis vaccine for at least 10 years certainly sees their health professional and has a booster as soon as possible. But unfortunately, the jury is out to when we should be giving a booster dose after someone's actually had confirmed pertussis. So in regards to our questions, we've got a poll here. What is the most common cause of death in people with pertussis? I'll give you a short moment to perhaps answer that question. Okay, you've done exceptionally well. Yes, the answer is B. Pertussis pneumonia, sometimes complicated by seizures and hypoxic encephalopathy. So well done. You did that nice and easy. Okay, so looking at burden of disease, you can see by this particular graph, we've got some peaks and troughs happening. The largest epidemic since, in this particular time frame, particularly since 2005, was the incidence in 2011, and you can sort of see that right in the middle of the graph there, where there are 38,755 notifications of pertussis in that particular year. But then if we look down the track, just at 2014, so only 3 years later, it was down to 11,863, which is still a lot of notifications, but significantly less than 50%. So we can see definitely that there are these peaks and troughs with pertussis notifications. Once again, in this particular slide, we can also see those peaks and troughs. Why are we seeing peaks and troughs? Well, there's a bit of, once again, the jury is out on this one to why, but there are some thought processes in regards to this. We do test more now, particularly since 2009, when we had a little, whoops-a-daisy pandemic of H1N1 swine flu, where providers were encouraged, anyone presenting with an influenza-like illness was to have a swab done. So swabbing became quite widespread in 2009. It was picking up a lot of pertussis notifications, as well as H1N1 infections. So there is definitely a change in the testing, more accessible, more sensitive testing is also available now. But also there is waning. We are very well aware of the waning of the diphtheria, tetanus, pertussis containing vaccines being an acellular vaccine. Acellular vaccine immunity isn't quite as robust as the old whole cell vaccine immunity. But we know with the old whole cell pertussis vaccines, there was, quite a number of febrile responses. The immune system recognised the whole cell as a bigger threat or a real life threat, and therefore mounted a really strong immune response, which pushed children's temperatures quite high. There were febrile convulsions. Some of those children went on to have some permanent neurological damage. So given that, there was decreased uptake of the pertussis vaccine at that time, and therefore that then spurred outbreaks of pertussis disease. So certainly vaccine manufacturers were very cognizant of the fact that the public had lost confidence in the vaccine and therefore needed to change the formulation, and then therefore it is now an acellular pertussis vaccine, but unfortunately doesn't give us long-term immunity. Our immune system does not remember pertussis well, whether it's natural disease or whether it's vaccine immunity. Unlike something like measles, where if you have had measles disease, you have got lifetime immunity. definitely not the case with pertussis. Our immune system, for some reason, does not build an immune memory that lasts for very long. If we look at burden of disease, then we can just see once again that we've got those high notifications. Interesting, when we look at the 47% of pertussis notifications were in children under the age of 15, and this is last year's data, that's concerning in the fact that, some of these people may have younger siblings in their family, which is putting those not fully vaccinated babies in the family at risk. But they're also school-aged children, and therefore they have quite significant exposure to other children in the schoolyard. They're playing school sports, etc., etc. But it also does mean that 48% of disease notifications were in people over 15 years of age. So these are individuals, adults that are travelling, they are all having babies, they're around babies, they've got a lot of friends, they're very, very social, study in universities, they're out in the workforce. So significant exposure to other individuals. So just really important as a health professional that we talk immunisation at every possible encounter that we have with our clients. So last year's cases of pertussis, obviously very different from all around the country. You've got poor old New South Wales that's almost drowning in pertussis last year. But, you look at Tasmania and, much smaller population, of course, but not as much disease at all. In regards to how things are tracking this year, year to date, for South Australia here, we're around about the 490-ish, 92 notifications, compared to about 1,267 notifications at the same time last year. So we're tracking a little low, which is really quite nice. Western Australia, if we've got anyone from Western Australia on, you're sort of sitting around about the 927 cases so far this year. Victoria, 1,191 cases. Queensland, up until the 30th of June, we've got some data. You were tracking at 631 cases so far to 30th of June versus 563 cases at the same time last year. So, yeah, just tracking a little higher than what you were last year. So we've talked about, the danger to little tiny babies with this particular disease. Babies, young children, particularly if they're not fully vaccinated, are particularly at high risk. Older children and adults have probably been vaccinated. They have probably been exposed to this particular disease. And therefore, if they were to contract this disease, then they may have a less serious disease. However, they will get that horrible cough that's just annoying, and it will continue and continue and continue for months. Certainly have been documented cases of rib fractures, very horrible. But also, you get people with terribly bloodshot eyes because they've put so much intraocular pressure behind those coughs that it's actually ruptured some vessels in their eyes. So really not a nice disease, and it's just so highly contagious, and it's so difficult to diagnose, like I said, in those first 3 weeks, particularly when people are infectious. So little babies, once again, higher risk of hospitalisation, higher risk of dying from this particular disease. Like I also mentioned before, these babies don't usually have this hoop. You usually do not hear a hoop in a young baby. They will become quite lethargic. they will have a coughing episode. They will quite often just stop breathing. And I remember many years ago hearing a story from a nurse that worked in Tasmania many, many years ago during a pertussis outbreak down there. And she was working in a children's ward, and there were babies in these little Humi cribs all around the room. And her job was to walk around the room and pull at a little string that was hanging out of the bottom of the cots. And that string was tied to the big toe of these babies. And by jiggling that big toe, it would just stimulate these babies to breathe again. And that was her job, was to walk around the room, literally shaking these babies' toes to get them to breathe. So, just a horrible disease for little babies. Children and adults, we've got a national immunisation program. We've got a really robust immunisation program in Australia, and it's something that we must be very, very thankful for and very, very grateful for. Children are vaccinated against pertussis, as you're well aware, at the 2, 4, 6 month mark. They get a booster dose at 18 months, and then they get another booster dose at 4 years of age. Because of that waning immunity, there is an adolescent dose that's given in this, usually throughout the school programs, and depending on which state you are in, will depend on when it's given. Here in South Australia, we give it in year 8, and other states will give it in year 7, so just check with your state and territory. In regards to the no jab, no pay legislation, there are free catch-up vaccines for people aged 10 to 19 years of age that may have missed out on having doses of pertussis-containing vaccine, and they can access those free of charge if they have a Medicare card or if they are a refugee or on a humanitarian visa. So this is how our immunisation program looks. So those first 3 doses are considered to be the primary course, and then they have a first booster at 18 months, a second booster at 4 years, and a third booster as an adolescent. Adults. Most adults do not know that they should have boosters against whooping cough. We speak to a lot of adults at community events, the pregnancy babies expos that travel around the country. And when we talk about whooping cough vaccines for adults, majority of adults that we talk to didn't know that they had to have one. They thought that their baby vaccines that they had would be enough to give them immunity for the rest of their life. So we do certainly find that we have a lot of adults scurrying to their provider for a booster as soon as somebody in the family gets pregnant. When somebody in the family is pregnant, then awareness starts to rise amongst that family group, and you'll end up with grandparents rushing in to have their booster doses because they've been told they're not going to get to see this baby until they've had it. And I think you've probably all come across those sorts of people. But definitely please offer this vaccine just to reduce that likelihood that they will become infected at some stage. So here's our pregnant women. It's now an NIP vaccine, which is just absolutely fantastic. So with the change to the immunisation schedule on the 1st of July this year, where we saw changes for the childhood program, the one change for the adults was the fact that the pertussis-containing vaccine for pregnant women is now funded through the NIP. In the years prior, we have actually been, the states and territories have been funding that program. The good thing about this vaccine coming onto the NIP is really around program consistency, because when it's a state and territory funded vaccine, different states and territories had different rules around who was eligible to receive the vaccine. And it also means that this particular vaccine program is not put at threat, whereas when it stays with state and territory governments, if there's other pressing needs happening in that particular state or territory, then the government may choose to close the program. So it's really, really pleasing for this vaccine to be on the NIP. One of the questions in the box is offer the vaccine every 10 years or sooner. There is some guidelines and in regards to when we should be offering boosters. At the moment, the handbook is saying if it's been 10 years, please have one. However, if you are a frequent traveller, they suggest having a booster at 5 years. But with pregnant women, it is given with every pregnancy, regardless of the interval between the pregnancies. So we know full well that we cannot overdose somebody with vaccine, particularly a DTPA vaccine. Yes, we may make their arm a little bit red and sore because of the tetanus component to the vaccine, but if you want to toss up between having a red sore arm for 4 or 5 days versus having whooping cough, I think most people will be happy to have the red sore arm. So just have a look at your patient's needs, whether they're travelling, whether they're at really significant risk. There are some hospitals that are certainly offering a booster to their healthcare workers, particularly those working in the midwifery units or neonatal units or on children's wards, etc., boosting them around about the 5-year mark. But that's sort of an organisational policy. Okay, so we've got another poll. So vaccination is recommended in the 3rd trimester of pregnancy, which includes. So we'll let you go because we've just talked about this and we've just given you the answer, really. So pregnancies that are closely spaced together, less than 2 years, or pregnancies that occur only if they're more than 2 years apart. Give it to them after they've had the baby every 3 years, or is it A and C? Okay, you did pretty well. The answer is actually A. So it's recommended in the 3rd trimester of pregnancies, and that is every pregnancy, even if they are closely spaced together. However, for those of you that sort of said the A and C, so you answered D, boosters postpartum every 3 years, we would certainly recommend giving a woman a booster dose after the birth of the baby if she didn't have a booster in her pregnancy, if she missed it for some reason. The reason that we want to give this vaccine in the 3rd trimester is to get an antibody transfer across the placenta to protect the baby. Yes, we're going to protect the mum as well, but this is about protecting this little baby. However, if the mum has missed that dose, we definitely do not want her to get pertussis, particularly while she's having exceptionally close contact, such as breastfeeding, co-sleeping, whatever the arrangement is, with a brand new baby. So we would definitely be offering her a booster immediately post-delivery. There was a question in the box in regards to when did the wholesale vaccine cease to be used in Australia and when did the acellular begin? On the NCIRS website, there is actually an historical table of events. So when certain vaccines came into Australia. So definitely double check that. But there was, quite major concerns around the DTP vaccine, the wholesale vaccine, certainly in the 1970s. When the changeover happened in Australia, I'm not 100% sure off the top of my head, okay? But just jump onto the NCRS website and they will certainly have that table there for you. So we've just been talking about that postpartum booster. So if they didn't receive that dose in pregnancy, definitely give it to them as soon as that baby is born. So we're going to prevent that mum getting infected and hopefully therefore passing it on to her baby. But, we would definitely be wanting health providers to be talking to pregnant women about this vaccine. Talk to them early in their pregnancy, that as soon as they get to 28 weeks, that is the best time to be giving this vaccine. The best time is between 28 weeks and 32 weeks because we know that early labour may well happen at any particular time. But hopefully if we can get this vaccine in and we can have 2 weeks before they have their baby, we know that those antibodies will be built and we know they would have transferred across the placenta to protect that little baby. So we certainly know that household contacts are really a frequent source of infection, particularly for those little babies. That's been very, very well established, and certainly parents, because they're having the closest contact with these little babies. So the big question then comes around, cocoon, what we call cocoon strategies. So let's immunise everybody possibly that's going to be breathing on that baby to help cocoon that baby, to keep disease away from that baby. And it's a really good strategy if the baby doesn't leave that cocooned environment. There's no point really having all of the family members vaccinated against pertussis for the benefit of the baby if you're going to be going to the shopping centre the day after, or even on your way home from discharge of hospital with a brand newborn baby. And we do see this. We see these little tiny brand newborn babies in shopping centres. They're in the schoolyard. They're everywhere realistically. So we used to quite often say, parents perhaps should start thinking about treating their babies like a newborn puppy. If anybody's had a new puppy, one of the bits of advice that you'll get from the vet is that do not take the puppy outside of your yard and don't let it mix with other dogs until it's had all of its vaccines. And people will do that with a little dog. They will certainly nurture it to that point. But that's not what happens with little babies. And life gets in the way, and it's unrealistic to expect that parents will stay home 24 hours a day for 6 months, really, even for 6 weeks until it gets its first vaccine. But we've just got to, protect as many people as possible at the end of the day. So just a question in the box. If a woman is planning pregnancy but not pregnant yet, so it could be months away, but she has not had an adult dose of DTPA for herself or for over 10 years, should she get a dose pre-pregnancy to protect her? or should she wait until she falls pregnant, but in the meantime she'll be non-immune in the lead up? Okay, so realistically, because we can't have a crystal ball to know when she will get pregnant. So if it's been more than 10 years, absolutely you could give her a dose of vaccine, absolutely, because it might be a long way down the track. But we would definitely still be offering her a dose of vaccine at 28 weeks because it's about getting those antibodies across to the baby. So hopefully that answers your question okay. So another one of the special risk groups are not only the household contacts, but anybody that's dealing with little children. So if you've got childcare workers that are part of your patient group, please talk to them. Occupational reasons, they should be completely fully vaccinated against lots of things, but particularly with pertussis boosters. And as a healthcare worker, also, please consider your own immunisation status against all diseases, including influenza, but also a dose of DTP if it has been more than 10 years since your last dose. There's a variety of formulations around, as we're well aware. Infanrix, obviously, we're giving it 18 months of age for on the schedule. Infanrix Hexa, we're giving it at 2, 4, 6 months. Infanrix IPV is on our schedule to be given at 4 years of age. But there are other brands out there, so just be aware that particularly children that are coming in from other countries may well have received other vaccines as well. Okay, so we've got another poll. Infanrix Hexa. Now, this is a bit of a tricky question, really. You might not know this. Infanrix Hexa must be reconstituted by adding the entire contents of the syringe to the vial, which contains the Hib pellet, and shaking it until the pellet is entirely dissolved. Once you've reconstituted that vaccine, it should be used as soon as practicable. If storage is required, is it A, B, C, or D? Okay, you did pretty good, but surprisingly the answer is D, holding it at room temperature for not more than 8 hours. But back here there was a question, what about that same woman? Oh, she's a problem lady, but this time she presents in early pregnancy. Should she wait until 28 weeks in that case, but will be non-immune during the first 2 trimesters? Yes, we would definitely be recommending that she waits until the 28-week mark to have a vaccine if she's already pregnant for sure. And yes, look, the truth be known, she's probably been non-immune for a number of years because it's highly unlikely that by the 10-year mark, people have got any antibodies left protecting them against pertussis, is the truth be known. So it'll be interesting to see whether that recommendation does get changed in regards to when we should be boosting people. But there's really good evidence of waning well before the 10-year mark. So we talked about formulations for DTP-A, so that's a capital D, capital T, capital P with a little a, and now we've got the adolescent or adult formulation, which is a small d, a big T, and a little p. So basically, the small letters just means smaller amounts of antigens than what's in the childhood vaccines. So your childhood vaccines are able to be used and they're registered for use in children up to 10 years of age. Once a child has had its 10th birthday, then you can no longer use the childhood formulations. The recommendation would be that you switch over and be giving them an adult or adolescent formulation, such as a Boostrix IPV if they were needing a polio booster as well, Adacel, or an Adacel polio vaccine as well. So we've got that 3-dose primary course, like I said. This is where providers really need to be very, very honest and very transparent about the vaccines that we give and the protection that those vaccines provide to individuals. 84% protective efficacy against severe disease. It does mean that fully vaccinated people can still contract this disease. However, we do know that in a vaccinated individual, they will have less severe disease. They will have a reduced risk of complications from that particular disease. So just be really honest and upfront with people in regards to, yes, we've vaccinated your baby. However, not all vaccines that we give are 100% effective in 100% of the people that we give them to. So even though Bubby is fully vaccinated, we still need baby kept away from anybody that's got a irritating cough, particularly if it's been persisting for some time. We've talked about the waning immunity and how quick that immunity may wane. We've certainly heard of vaccinated healthcare workers that received a booster vaccine 2 years ago having pertussis disease. So immunity is not long-lasting by any stance, but also we also know that the vaccine is not going to provide 100% protection in the first instance anyway. So if we have adults and adolescents vaccinated, the degree of protection is relatively good. So if we can vaccinate our community against this disease, we are going to be protecting those younger children who may not be responding as well to this particular vaccine. So once again, I just keep on reiterating to health professionals, talk vaccination at every possible chance you get with everybody that's coming into your practice or your organisation. Vaccinating pregnant women in the UK up to at least 7 days before delivery, which is quite interesting because we normally talk about a 2-week window for antibodies to be built and then to be transferred. But, just even if you can get that vaccine in up to 7 days, there's really good evidence that there was reduced pertussis disease in those infants that being born to vaccinated women. So the evidence is there, so please have those conversations with pregnant women. We talked about cocooning before. It's a great strategy, but the baby needs to stay within that cocooned environment to be, protected well from a cocooning strategy. In regards to some questions here, why don't they make the boosters closer together if the vaccines don't last long? Look, that's the jury is out once again, Marnie, on that one. This is a conversation that's happening all around the world. We've got, there's big key experts in the pertussis that are talking this through. And look, one would potentially expect that recommendations will change at some stage, but I think there's more conversations really to be had in regards to what's the best measure, because we can't there's not an antibody titer that we can measure, and I think that's the problem with pertussis. So not like with hepatitis B, you'll take a blood test, and if they, are immune to hepatitis B, it's a nice marker of 10 million international units that we'll see on their serology results. And we just don't have that with testing for pertussis. We don't have a marker of immunity. So that's a bit of a problem. How long before a grandparent has contact with baby is it okay to have the vaccine? Look, we usually, the parent can have contact with the baby at any time, but if we want grandparents to have immunity, or as much immunity as we can possibly give them with a booster dose of vaccine, we know that it takes about 2 weeks for those antibodies to build. But as long as the grandparent doesn't have active pertussis disease and doesn't have a cough, etc., realistically they can have their vaccine and go and see the baby any time. Carolyn, have vaccine yet if they were vaccinated, say, 2 years prior? Look, the recommendation at this stage, Carolyn, is if it's a grandparent and they had a vaccine 2 years ago because they had another grandchild being born at that stage, the recommendation is actually saying to boost at 10 years. And that's what we need to go by realistically at this stage. So vaccine safety, just very quickly as we're coming to the end of our time. We talked a little bit earlier about those whole cell pertussis vaccines, so the old DTPW, you might see written. Some countries still use a DTPW, but we certainly haven't used it for quite some time here in Australia. But definitely fever was one of those adverse events following that whole cell pertussis vaccine. Local reactions, there were more significant local reactions, and that was just really the strong antibody response to the vaccine. Because the immune system, like I said, was recognising the whole cell. Even though the cell, there was no living particles, it was still a killed vaccine, an inactivated vaccine. The immune system recognises the whole cell as more of a threat than just having a piece of the cell presented, such as now with the pertussis vaccines that we have. So extensive limb swelling, really the diagnosis or, the marker for extensive limb swelling realistically, if the swelling and redness involve the joint above or the joint below the injection site, it's considered to be a reportable adverse event. But if an individual has a big red swollen arm, but the joint above or the joint below are not involved, then technically it's not really a reportable adverse event. It's just a large injection site reaction. You would expect that these reactions will start to settle. They cause more distress to the parent than they actually do to the child. It is not a contraindication for them to receive further doses of a pertussis-containing vaccine. But they usually, they will resolve completely. Vaccine given in pregnancy certainly is safe. There is absolutely no evidence that it causes any complications with pregnancies at all. So definitely talk to your mums about the safety of this vaccine, and the benefits of this vaccine absolutely far outweigh any risks at all in regards to, yes, mum might get a red swollen sore arm. Benefits are much, much more than that. Obviously, with any vaccine that we give, there is really only the absolute contraindications to vaccines are that they have had a previous anaphylactic reaction to that vaccine previously, or they have had an anaphylactic reaction to a component of the vaccine. It is a non-living vaccine, so it's fully inactivated, which means that this vaccine can be given to people, if they have immune compromise or clearly are pregnant. And they are the other two contraindications that exist, but only relate to live virus vaccines. And you would be well aware we do not give a live virus vaccine to pregnant women. It's not recommended, or to somebody who is immune compromised. So in regards to treatment of somebody that presents with pertussis, antibiotics definitely are the way to go. There are a range of antibiotics that can be used, as you can see. The antibiotic action will just reduce the transmissibility of this infection to others. If the individual's been coughing for more than 3 weeks, generally the infectious period is now over, and therefore you wouldn't start them on a course of antibiotics. So this comes back to what I was saying before. Early diagnosis is really key, to let that person know that they've got an infectious disease and to stay away from people, but also to commence them on a course of appropriate antibiotics. Antibiotic prophylaxis in regards to contacts of cases, they are recommended in certain situations, such as in children less than 6 months, in contact with a pertussis case, so if mum or dad or another family member's been diagnosed. You will get guidance from your state health department on who should be receiving prophylaxis antibiotics in relation to a pertussis contact. So will the antibiotics reduce the time of coughing? Generally, no, they don't. They will just interfere with the transmissibility of the infection to others, but it will also reduce any likelihood of complications to this particular case, such as a pneumonia. So, in conclusion, right from the start, we said this is a really contagious respiratory infection. It spreads very, very easily. Major symptoms are the cough. Like I said, they can be paroxysmal. You watch a little baby have a whooping cough episode, and it's really cruel. These babies will really be very, very compromised. And they will have a number of bouts of coughing episodes during the day. Adults probably cannot string a sentence together before they actually have to have a coughing fit in between. It does cause death in infants more so than it does in older children and adults that get pertussis. So those little tiny infants are the highest risk for dying of this disease. We've got free vaccines available for certain individuals, but reducing pertussis in infants really is about making sure that anybody breathing on that infant has been vaccinated against whooping cough. So just recommend these boosters all the time. And thankfully, this vaccine is now funded under the National Immunisation Program for pregnant women at 28 weeks. So just continually offer this vaccine to everybody that you see. So give the first infant vaccine at 6 weeks. That is the recommendation. The schedule, some schedules will still say 2, 4, 6 months, but these vaccines are licensed for use from 6 weeks of age, and some state and territory schedules will have maintained that we still give that dose as early as we possibly can, because it will boost that baby's antibody protection against this disease. Yes, it will have some maternal antibody there, But the sooner we give this baby some protection of its own, the better for the baby as well. So, yep, definitely you can vaccinate at 6 weeks of age. So what is the rationale behind giving the vaccine at 28 weeks and not earlier? Look, that's an interesting question, Anne, because other countries do give this vaccine in the late stages of the second trimester as well as the third trimester. It's been a line in the sand that Australia has put at the third trimester, but looking at antibody transfer, they do believe there's good evidence to say that that is the optimal time for antibody transfer from mums to babies. Unfortunately, the DADs are not funded for the 3 vaccines. Under the state and territory run programs previously, some states did include the DADs, did include grandparents. South Australia has only ever vaccinated the pregnant woman at 28 weeks. It has not extended the program to anybody else. And the NIP is just for the pregnant women. But certainly encourage the dads and the grandparents and everybody else. So I'd really like to thank you. Our time is up. I'd really like to thank you for your attendance. I really hope that, everybody's walking away just with one new piece of information. And, hopefully you've all done this from home and you don't have to travel, but if you have got together with a group and you're travelling, do it safely. Victoria apparently is funded for dads if no booster for 10 years. So that's absolutely great, Marianne. Good for you. So a state-run program still happening there. So fantastic. So thank you very much and good night.